Good morning. Can you guys hear me okay? My name is Tesfaye Telila. I'm one of the interventional cardiology fellows. Welcome to our weekly cardiovascular grand rounds. Today, I'll be talking about rheumatic heart disease more in a global perspectives and some epidemiologic aspects of the disease. And finally, if we have time, I'll go over mitral stenosis and pregnancy and the ramifications. I'll start by talking about why we should really talk about rheumatic heart disease in a country, in a setting where the apparent incidence and prevalence of the disease is not really that high. And we'll go over the definition of the disease, a little bit of epidemiology, pathophysiology of the disease. We'll go over the diagnostic criteria for acute as well as chronic rheumatic heart disease and some management and prevention. And like I said, I have a few slides with mitral stenosis and pregnancy as well. So why talk about rheumatic heart disease? As you probably know, this is the most important preventable cardiovascular disease. And it affects, to date, a very large proportion of children and young adults living in the developing world, which comprises about 80% of the population in the world. And with a conservative estimate, about 15.6 million people are currently affected by this disease. And it disproportionately, obviously, affects people who are children and living in developing world, that giving the chance that actually it has a very high disability adjusted life years. And WHO in its last year annual report actually called it as a neglected heart disease of the poor, where actually my topic comes from. And more interest to us here in the United States is the population dynamics due to migration and refugee crisis kind of destabilizing the world a little bit. We'll keep seeing more and more of rheumatic heart disease in America. The disease has been reported to be underfunded as compared to these three other diseases of public health importance, which is HIV, TB, and malaria. As you can see, it causes about 1/5 of the disease, that's the mortality that's caused by HIV. However, the funding, which is the annual funding that goes to this disease, both for research and treatment, is actually up to like 1/1000 of HIV. And that has a number of ramifications in terms of disease prevention and treatment. And a number of editorials and review articles have been written in this regarding the funding of this disease. The apparent incidence and prevalence of the disease is low, but that doesn't mean the affluent society should be okay with that. So it has to be actually paid more attention. The story of rheumatic fever is not that of a story of polio. It's not eradicated. It still gives a lot of mortality and morbidity. Here in the United States, the last resurgence of acute rheumatic fever is just over 20 years ago, which in epidemiologic terms is not too many years. And unfortunately, the disease pattern that was seen in America was actually a little bit different, that in such a way that it affected predominantly white middle-class families with above average income with ready access to medical care, which brings the question that it may not entirely be just the poverty and overcrowding. It may also have something to do with the type of streptococcal bacteria that we have in this country. So the authors actually concluded that rheumatic heart disease remains an important health problem in the United States. If you see global health today, it is it is actually one of the biggest, expanding areas of medicine, including our own institution here. We have a number of global initiatives through Global Health Institute and global pathways from internal medicine department going to all over Africa and Asia, where we have programs right now. Even in my own country, Ethiopia, there is internal emergency medicine and family medicine, as well as OBGYN residencies. The main goal being student exchange, experience exchange, and exposing the future generation to the different epidemiology of diseases. So coming to what what the definition of acute rheumatic fever is obviously it's a delayed non-suppurative inflammation or reaction following a group A beta hemolytic streptococcus pharyngitis, and the disease tend to actually affect some extra cardiac structures, joint spaces, and the brain, the skin, and subcutaneous tissue. However, the predominant problem after this disease is the cardiac involvement, because the other systemic involvements tend to resolve completely. The last updated, the last review about the epidemiology, both national and the global burden of rheumatic heart disease was recently actually reported in New England Journal of Medicine by Watkins et al. This was supported by the Gates Foundation, and obviously, as you know, the incidence and the prevalence of the disease is actually on the decline. From 1990 to 2015, almost half of the disease, the mortality caused by this disease has gone down, which is a good sign, but it's not enough considering the fact that the disease is actually preventable. All over, the globe, the disease has declined in terms of prevalence, but the disease still remains endemic in part of Africa, West Africa, East Africa, South Africa, Asia, and Oceania, but you can, barely really see any new cases of rheumatic fever in the developed world. And the penicillin seems to be the highest impactful drug for this disease, and the bacteria remains susceptible for penicillin, so a secondary prevention seems to be the key. So what really happens with this disease? It's a very complex disease, but so far what is known as to why these kids with very simple throat infection go on to develop this very chronic and long-standing cardiovascular problem is at the heart of it is what's known as molecular mimicry. So group A beta hemolytic streptococcus causes pharyngitis, and like it does for any other disease, the body recognizes the bacterial antigen, and it mounts through the antigen presenting cells. The antigen will be presented to T cell receptors and B cell receptors, and the body, as it does for any other infection, will actually produce antibodies. But the problem is that these antibodies, they kind of confuse self from non-self and tend to attack the own antigen. And it happens that those antigens are also distributed in all these 5 organ systems: the heart, the brain, the joint, skin, and subcutaneous tissue. But luckily for the patients, most of this extra cardiac involvement, they tend to resolve completely. Just use this slide. The process where the body's antibodies confuse self from non-self is basically known as molecular mimicry. And the skin is the first organ to be involved, and mostly the way it shows is with this macular erythematous lesion that is centrally healing and peripherally active, mostly affecting the trunk and the lower part of the body. It almost never involves the face. It's non-pruritic, not painful at all, and it's inconsequential. The skin lesions, they resolve completely. The only clinical significance of the skin involvement here, it's actually a sign of carditis. If kids develop bad skin lesions, they are more likely to develop carditis down the road. Subcutaneous nodules, very similar. They're very inconsequential. However, they actually affect the extensor surface of the body. This is kind of a classic side. They also don't really cause any long-standing problems. Here is chorea. It's also called Sydenham's chorea or St. Vincent's dance. It affects the brain just like any motor abnormality causing diseases. It causes destruction of the basal ganglia of the brain, and these kids would present with abnormal, purposeless motor movements that are really scary to the parents. And when they have joint problems, concomitant joint problems, they have joint problems which is very painful. Now they have this purposeless motor movements, which makes the situation very difficult. Unlike the others, the chorea does not resolve completely right away. It actually lasts months, and it also affects the kids, school attendance and cognitive and some behavioral problems as well. The joint involvement, it typically involves the major joints, the big joints, and it could be arthritis or arthralgia, and it also does not really leave long lasting problems. So obviously the main problem that we're concerned is the carditis. Carditis from acute rheumatic fever is usually pancarditis. It involves the entire layer of the heart, from the pericardium to epicardium, myocardium, and endocardium. The most important being the valvulitis that's caused by acute rheumatic fever, which is where the layer of the endocardium is involved. And that's kind of the universal finding in this disease. You may have acute rheumatic fever and you may not have myocarditis, but if you have carditis, you will have to have endocarditis or valvulitis. And obviously the clinical diagnosis of carditis is attack of rheumatic fever, presence of regurgitant murmurs, usually mitral regurgitation and aortic regurgitation, and pericardial friction rub, and unexplained cardiomegaly. And this develops in 80% of the patients actually 2 weeks after acute rheumatic fever. And if a patient dies from acute rheumatic fever, they almost invariably die from myocarditis, acute heart failure and decompensation. Like I said, endocarditis or valvulitis is a universal finding, and the most commonly affected valve is the mitral valve, and it could be affected in isolation or in combination with other valves. And followed by the aortic valve, and most commonly associated with regurgitant murmurs. Sometimes you may see a diastolic, mid-diastolic rumble, which is called Kerry-Combs murmur. It's actually due to turbulent flow, volume overload, and diastole. You may actually hear a mid-diastolic rumble. It's just because of the inflamed and swollen mitral valve apparatus. Severe mitral regurgitation is also a poor prognostic sign down the road, and the chances of these kids developing severe mitral stenosis down the road is very high. So this is basically what happens. Since the mitral valve is a high-pressure closing valve, at least so far what we know is the tips of the mitral valve leaflets, which the commissures, the closure line basically, it gets kind of destructed, and it forms some small sterile vegetations. Those vegetations, they don't tend to embolize, they're very stable. However, in due time, as there's healing, they tend to fibrose and kind of attach together. That's why the pathognomonic finding in rheumatic mitral stenosis is basically commissural fusion. The commissures fuse. However, the mitral regurgitation can also be caused by mitral annular dilatation, leaflet prolapse, chordal elongation, and sometimes even chordal rupture can be a problem. I will show you an echo of that. So the diagnosis of acute rheumatic fever is clinical, and the first was, diagnostic criteria was proposed by Dr. Duquette Jones in 1944. However, it has been updated over the years. Actually, I don't have the last one. The last one was 2015 by AHA. It is just the major, minor, and evidence of streptococcal infection. The major criteria, as you can see, is the organs that I just talked about, being carditis being given in a very strong clinical importance. Of course, if you have one of these four, arthralgia, fever, or elevated acute phase reactants, you will have minor criteria and evidence of streptococcal infection, pharyngitis. If you have two of the major criteria, or one major and two minor, just very similar to the Duke's diagnosis of infective endocarditis. However, in this day and age where people tend to do echocardiography, this is not enough, and echo criteria has been added. ECG, there's really no one sign that will diagnose acute rheumatic fever on the EKG, but these kids tend to be tachycardic, and most importantly, tachycardia during a non-exertional state, even when they're sleeping, seems to be a sign of bad carditis. Of course, they will have high grade, they may have heart blocks and congestive heart failure as well. This is the echo of a patient with acute rheumatic fever. As you can see, as you can see here, you will see the chordal structure. There is really no calcifications or anything like that, but there is, the leaflet is actually, the anterior leaflet is kind of damaged here and it's prolapsing. And they also say there is annular dilation, but it's kind of very difficult to assess the mitral annulus, as you know, is a very saddle-shaped structure. And there is the posteriorly directed mitral regurgitation jet, and the left atrial size is normal, and there is mildly reduced ejection fraction, which shows you there is evidence of carditis there. So the treatment of acute rheumatic fever, obviously, is the group A beta-amyloid streptococcus penicillin. Arthritis can be treated with aspirin, naproxen is second line. Carditis, obviously, treatment of heart failure. And erythema marginatum and subcutaneous nodules, they don't really need any specific therapy. Chorea is also self-limiting, but haloperidol and carbamazepine can be tried. Surgery sometimes, rarely may be needed even in the acute setting if patients are in cardiogenic shock. And however, the problem is the tissue is very friable and the outcome of the surgery is not very good. So in the basic principle of medical therapy, secondary prevention of rheumatic fever is indicated. It's a class 1 indication, level of evidence C, when patient with rheumatic heart disease, particularly if they have mitral stenosis. The question is, how long do we treat this patient for secondary prevention? If it depends if they had carditis during their acute rheumatic fever or not. If they have carditis and also if they have long-standing valvular heart disease, which is mitral stenosis in this case, you have to treat them at least for 10 years after the last attack or until they are 40 years of age, whichever is longer. But depending on the type of recurrence and how late in their life actually they develop the mitral stenosis, you may need to treat them for life. If they don't have mitral stenosis, but if they had rheumatic fever and carditis, you can stop the therapy at the age of 21 or 10 years after the last attack, whichever is longer, basically. There are different, opinions from different bodies, including the WHO, which kind of suggests we have to treat them lifelong. But I just took from the HA guideline. This is what we think. How about chronic mitral stenosis, chronic rheumatic heart disease? This is probably something that we kind of more used to than the prior echo. This is a long-standing mitral stenosis and also mitral regurgitation with enlarged left atrium, as you can see here, and the subvalvular apparatus is kind of calcified and thickened. As you can see, there is the hacky-stick deformity of the anterior mitral valve leaflet, which is kind of classic for mitral stenosis. And also you can see there is some aortic regurgitation here. The hemodynamic consequence of mitral stenosis is not that difficult. It's very straightforward. It all starts with mitral stenosis here. The left ventricle seems to be protected. Also, these patients, they have mild degree of LV dysfunction for a very unclear reason, maybe due to the earlier attacks of acute rheumatic fever. Otherwise, the left ventricular systolic function looks okay. So the main problem is basically diastology. So the left atrium is the most affected structure here, and there will be left atrial hypertension and stasis, and these patients, they have atrial fibrillation. Stasis and thromboembolism will be the main issue here. And then there will be obviously, rarely you may have ASD in these kids, and they will be left to right shunting. There will be long-standing pulmonary venous hypertension, and patients may develop paroxysmal acute pulmonary edema and hemoptysis. And if the pulmonary hypertension is long enough, they may actually have irreversible pulmonary vascular remodeling and long-standing pulmonary hypertension, which may be reversible even if you fix the mitral stenosis. And subsequently, they will have right-sided heart failure, cor pulmonale, severe tricuspid regurgitation. RV will be large and baggy, and RV failure will ensue, and then they will have congestive systemic congestions with hepatic congestion causing congestive hepatopathy, even cardiac cirrhosis and reduction and actually synthetic function of the liver will be poor, and these kids will have very bad anasarca, and also there will be gut edema, and they won't be absorbing any proteins. They will have protein losing enteropathy, and then that's kind of the vicious circle. At this point, even if you do something, mortality will still be high. So the earlier you intervene before they develop all this systemic failure is the better. A clinical presentation is exactly what I just said. It is a sign of right and left heart failure if it's so late, but something that you have to kind of know. In that setting, the patients may actually present with massive hemoptysis. This is rare. This is actually not the typical chest X-ray finding for acute chronic rheumatic heart disease. But if you leave it untreated, this is basically what happens. The left atrium will be so enormously large, and the left main bronchus may be actually elevated, as you can see here. The left atrium may be so big that it may actually compress on the esophagus. Patients may develop with dysphagia. It may compress on the recurrent laryngeal nerve, and they may develop hoarseness, like this patient that was reported in New England Journal of Medicine. She actually had a mitral valve replacement, but it was done late during the course of the disease. As you can see, the heart is huge and globular, and the pulmonary vasculatures are actually not that bad. There is the pulmonary artery enlargement, but there is no acute pulmonary edema type of picture. Physical examination, basically, findings that you see on left and right heart failure, anasarca, and mitral feces is not that common, but again, if you leave it untreated, patients may have bimalar flushing, which also is a sign of long-standing untreated mitral stenosis. As you know, the murmur of mitral stenosis is a diastolic soft rumble, heard best with the bell of the stethoscope. And in terms of severity, the left atrial pressure is so high, actually, the mitral valve snaps open even before the isovolumetric relaxation is complete. So after the second heart sound, the closure of the aortic valve, you hear opening snap. And in terms of severity, just like aortic stenosis, the duration of the murmur, the longer the duration of the murmur is, the more severe the mitral stenosis. And the closer the opening snap to the aortic closure, A2, is the more severe the mitral stenosis. Just that tells you how there is a very high left atrial hypertension and the mitral valve actually snaps open. Echo, needless to say, is the cornerstone of diagnosis as well as stratifying the severity of mitral stenosis. And if you have a suspected case of MS, of course, you have to do echo, and there are, techniques to actually, these are the techniques that you can use to stratify the severity of mitral stenosis. For this particular reason, you can use any of them. The pressure half time seems to work good as far as you haven't done mitral balloon valvuloplasty, but after balloon valvuloplasty, that seems to not work because of the change in the hemodynamics. And planimeter, especially if you do it with the 3D planimetry, seems to be the most reliable way of assessing the mitral valve size, even before and after intervention. And the continuity and PSA can be used. If you use, it's a little bit more cumbersome than the other two techniques. If you use PSA, just don't forget to correct for the angle. Cardiac cath is not indicated for diagnosing mitral stenosis, but sometimes you may have a situation where echo is maybe inconclusive due to poor window or some other reasons. You may consider doing it. The only time that you may do cardiac cath is basically, hemodynamic cath. That's what I'm trying to say. Pulmonary vascular resistance, you may not get from the echo. You may, but it may not be reliable. And if the patient is going for surgery, obviously a coronary angiogram, if they're older than 50, is indicated. Complications, very straightforward. Thromboembolic complications are the most important, most dreaded complication of mitral stenosis. And acute decompensation heart failure is very common when they go into atrial fibrillation, as you can tell. That the core of mitral stenosis is diastology. There is no filling. Filling is the problem. Therefore, these patients tend to depend on the atrial kick, right? If they have atrial fibrillation, now rapid ventricular response, the diastolic time is going to be compromised. So they will not have any time to fill, and even if at the end of the diastole, when they're supposed to get their atrial kick, now they're in AFib and they don't get any filling. Therefore, forward flow is going to be very problematic. And in terms of thromboembolism, mitral stenosis, when it's valvular atrial fibrillation, the thromboembolic risk from the Framingham study is very high, about 17-fold higher than the others. And embolic events tend to be cerebral in nature, and they tend to be recurrent. Therefore, patients, these are kind of straightforward recommendations. They have to have transthoracic echo to 1, diagnose, 2, assess the severity, and 3, to assess the favorability of the valve for mitral balloon valvuloplasty. And in terms of TEE, TEE is only indicated to do 2 things. 1, to rule out if they have left atrial thrombus, or to assess the severity of the mitral valve if they're going for commissurotomy. Exercise, sometimes there will be discrepancies between the mitral stenosis and how the patient feels. In that case, you may do exercise that can be done by Doppler, which is again a class 1 indication, or it can also be done by hemodynamic invasive cath if for some reason you cannot do it with echo. Very simple to do. The CW Doppler across the mitral valve and the tricuspid velocity with PW. You can see here as the workload increases, the transmitral severe gradient goes up, which was 5 at rest, and with the workload, which is nothing. If you go to 20 to 80 watts of work, it's 29 millimeters of mercury. As you can see, that the TR, pulmonary systolic pressure, also goes up concomitantly. So these patients may not be symptomatic at rest, but if when they do something, that's why they have very bad symptoms. You can do the same thing with cath, park the PA pressure, pulmonary wedge pressure, and also you can calculate the gradient. Here, as you can see, there's a little bit of phase shift that I have to go back. But if you want to get the real gradient between the LV and LA, obviously you have to do transeptal, which is more reliable. In terms of wedge, it seems to be overestimate the severity because of pulmonary venous hypertension. Anticoagulation, very clear. It has to be vitamin K antagonist, it has to be Coumadin. If this is valvular atrial fibrillation, you cannot use the NOACs. If they have AFib or prior embolic events, or if they have left atrial thrombus, obviously. What to do with these patients in terms of intervention? This is the last ACC/HA guideline from 2017, and severity is used to be less than 1, but now any valve area less than 1.5 square centimeters is severe. And transmitral gradient is actually, it's not part of the severity anymore, because the gradient depends on what the patient does and how active or sedentary they are. So we now depend on valve area or pressure half time, basically. So if you have severe or very severe less than 1, severe less than 1.5, and if you're symptomatic with favorable anatomy, very clear, balloon mitral valvoplasty is class 1. If you don't have favorable anatomy, and if you're in class 3 or 4 symptoms, high surgical risk, you may consider balloon mitral valvoplasty, but obviously there is risk there. You don't have favorable anatomy. The Wilkinson score is kind of high. You may run into a problem. That's kind of salvage. But if you don't have high surgical risk, you go for a surgery. So in this case, actually, balloon mitral valvoplasty has preference over surgery. So if you're asymptomatic and favorable morphology, no left atrial thrombus, and if you have severe, very severe mitral stenosis, which is less than 1, it is class 2A to consider balloon mitral valvoplasty. The other thing here is a little bit difference is if you have asymptomatic and the new onset atrial fibrillation, and if you have favorable anatomy, you may actually consider doing balloon mitral valvoplasty, just to, because some of the atrial fibrillations and pulmonary hypertensions actually resolve completely after balloon mitral valvoplasty if it's done early, before permanent pulmonary vascular change actually happens. Medical therapy, obviously I said this already, at the heart is diastology. Filling is a problem. Heart rate control is the mainstay of therapy. Beta blockers, preferably. If they don't have cardiomyopathy, you can also use calcium channel blockers, diuretics, and like I said, the filling is the problem. And if there is no atrial kick, these patients, when they go into atrial fibrillation, they feel horrible. Management of complications and contraception, because pregnancy and mitral stenosis, they have very adversarial relationship. If you have time, I will go over that in a little while. But severe mitral stenosis, you have to do something about it, particularly if they are symptomatic. Surgical mitral valve replacement can be done. Usually it is with mechanical valve because of 2 reasons. 1, these patients, they're already on anticoagulation for atrial fibrillation. 2, they're very young, so they're going to need the reoperation. So it is preferable to go for a mechanical valve. Of course, they are very young. Again, they may, the women may get pregnant, and anticoagulation is going to be an issue, but there's really no win-win there. At the heart of rheumatic mitral stenosis is commissural fusion. We said that. So if it's commissural fusion, the best way to address this problem is really to do commissurotomy. So people have tried to do commissurotomy as early as 1948. The first closed surgical. There's really nothing closed about it because you do thoracotomy. The only reason they call it closed is because they don't open the ventricle, and the surgeon, he or she, does not actually get to look at the mitral valve. They just do, it doesn't require cardiopulmonary bypass. They open the left atrium and they send their finger and kind of dissect the commissures with finger. So that will, it did very well actually. We don't do it anymore, but when it was performed, it did very well. The only problem was there was a lot of thromboembolic phenomenon. These patients end up getting strokes and distal embolization. So that's kind of historical significant. And then surgical, open surgical commissurotomy with cardiopulmonary bypass, where you actually open in the surgeon's view, left atrium is open, and the surgeon actually dissects the commissures. And this is helpful because if they have concomitant mitral regurgitation, they can also drop annuloplasty ring. The only downside is these are young people. They may need something done down the road. In that case, that's going to be a reoperation, so it's going to be a little bit of an issue. Otherwise, it does just as good as then comes the percutaneous options, which are the mainstay of therapy. A percutaneous balloon mitral valvuloplasty can be performed with a metallic commissurotomy, which is this, or it can be done by balloon, which is the NOA balloon, which is the most commonly used balloon worldwide. And it was the first balloon devised by Dr. Inoue, or the surgeon, a cardiothoracic surgeon from Japan. And the commissurotomy was actually first invented by Dr. Alan Cribier, who also is the person who put the first transcatheter aortic valve and did the first aortic balloon valvuloplasty. The purpose here is because mitral stenosis happens in the most disadvantaged and most economically challenged world because you cannot reuse this balloon. So since you cannot reuse this balloon, the idea with Dr. Cribier was actually to make something that can be re-sterilized and reused. But unfortunately, this technology remains to be the preferred and works the most. The most important thing in terms of success when you do balloon mitral valvuloplasty is patient selection, just like most of the things we do. And of course, operator experience is very important. And in terms of patient selection, it all depends on echo. So what does the valve look like? What are the mobilities, the thickness, calcification, and what are the subvalvular apparatus look like? So that is several echocardiographic scores have been proposed, but the most commonly used worldwide is the Wilkins or Wilkins-Abascal, the fellow and attending score. And it does give some very subjective scores, 1 to 4, the highest 16, the lowest 4. And if you have a score of less than 8, that seems to predict a very successful long-term outcome. It doesn't tell you anything about the chance or you may develop mitral regurgitation during the procedure, unlike what we often think. But this is not a perfect scoring system. The most important drawback being it doesn't tell you anything about commissural calcification, which seems to be the most important thing that you want to know, because that is where you're cracking. That is where most of the mitral regurgitation actually happens. People have proposed other scoring systems that will tell you more about the commissures, but these are just in kind of pipelines, haven't been ready for a prime time, but they actually seem to very appealing, where the anterior mitral valve, posterior mitral valve leaflet, these are the commissures. You can just divide the commissure, the anterior lateral, posterior medial commissure into 2, and 1 or 0 is what you get. The highest score is 4, and that will tell you very calcified commissures. And if you don't have any calcification, that's going to be 0. It's a 2D short axis here. As you can see, this is calcified. Anterior lateral commissure is calcified, no calcium. and this is a score of 2, which is an intermediate score. But this is not obviously prospectively same in terms of outcome, and I don't think it's ready yet. Percutaneous mitral balloon valvuloplasty, like I said, it was invented by Inouye back in 1984. And the balloon catheter itself is really nicely done. The balloon catheter is made of polyvinyl chloride. The balloon itself has 2 layers of latex with a polyester mesh in between the 2 layers. And the very interesting thing about this balloon is actually it doesn't inflate all at one time. The distal segment of the balloon is the one that inflates first. That will give you anchor in the left ventricle, and you can pull it back against the stenotic mitral valve. And when you inflate next is the proximal segment that inflates, and the last, because of the difference in the elasticity of the balloon, the middle segment actually inflates last, which gives you that nice crack splitting of the commissures. This is the balloon. It comes in 4 different sizes, from 24 to 30 millimeters, and the size selection is very kind of easy. You divide the height in centimeters by 10 and plus 10, the rule of 10. It works just fine. And depending on the presence and absence of commissural calcification, you may up or downsize or the amount of fluid that contrast and fluid that you actually give. I don't want to go into the details of the techniques, but what's very important from the time of Inouye is that now how much imaging guidance we use. The imager is really an integral part of this procedure. TEE is the most used technique, and it has to be done before you start the procedure. Rule out any evidence of left atrial appendage thrombus, rule out that they don't have moderate or severe mitral regurgitation, and that the TE will give you guidance with the balloon inflation and also presence and absence of complications. ICE catheter has been used. Most of the data regarding ICE comes from University of Colorado. They say they've used it very well, and they say it actually better in terms of telling you what the subvalvular apparatus looks like, but it doesn't really give you good area calculation and mitral regurgitation. So I haven't seen it used. This is just to tell you, if you have left atrial appendage clot, actually not in the US, but it's not a class 3 indication as far as you anticoagulate those patients for 3 to 6 months, and the clot actually is smaller in size, and if it's confined to the left atrium, you can actually do balloon mitral valvuloplasty. In that case, you just have to make sure that the balloon goes to the left ventricle over a wire, and there is no chance that you kind of deal with the left atrium. In terms of success, obviously area with planimeter is the most important thing. If you go over area of 1, that success and gradient should drop, and in the absence of mitral regurgitation. This is just to show how successful you are. Every time you get moderate or severe mitral regurgitation, needless to say, you have to stop. Pulmonary pressure may reduce right away, but like I said, it may not go away completely. The outcome of the procedure is very good, especially in the US, about 70% in the United States, and NHLBI also gives us reassuring numbers. This is the Wilkins score. I already said it. If it's less than 8 or greater than 12, it will give you prognostic values. But if it's intermediate, 9 to 11, it doesn't really tell you anything. So it depends on the clinical situation. If the patient can go for surgery, prefer surgery. If they cannot, you may consider, like I said, it's a 2B doing balloon. In terms of contraindications, obviously, if you have something like this is actually a patient, 60-some-year-old Asian woman who is in the hospital right now, in this hospital, who came in with congestive heart failure and had huge left atrial clot, so she ended up going for surgery, mitral stenosis, which is rheumatic, and also mild, at least mild mitral regurgitation. these are the other contraindications, obviously. Stenosis is going to be an issue. There's really no higher limit of so how many times you can do this procedure. By definition, stenosis is losing like more than 50% of the area that you have gotten during your first procedure. And it can get up to 40%. The last time we did one here, the patient actually, that was her third mitral balloon valvoplasty. She gets good result after every procedure. As far as she doesn't have any contraindications for doing this procedure, it is safe to do it. Obviously, these are the complications. Sometimes you may run into iatrogenic ASD since you dilate the septum. Just a slide on aortic stenosis. Rheumatic aortic stenosis, if you do balloon valvuloplasty, unlike the calcific, degenerative, age-related aortic valve, the result is very good, very durable. So if you do, obviously, balloon valvuloplasty for this, you know what happens. You may get any bridging. You may get a little bit of improvement in symptoms, but the recoil capacity of this is huge. In a couple months, the valve area is the same and the gradients are the same. That's why there's really no class 1 indication to do a BAV for calcific degenerative aortic stenosis. But for for rheumatic aortic stenosis, the problem again is commissural fusion. So if you balloon that valve, unless sometimes you may run into a severe aortic regurgitation, pulmonary edema, but if it works, the result is very durable, just as good as the mitral. So pregnancy and rheumatic heart disease, they have a very bad adversarial relationship. There is increased volume during pregnancy. There is tachycardia, which is physiological. Extra work during the second stage of labor. Obviously, that will be the time that they fail. And third stage of labor, where there is fluid shift from the uterus to the systemic circulation, from the placental circulation, there will be autotransfusion to the heart, which is very diseased with severe mitral stenosis, cannot handle that kind of load. So they decompensate. The mortality is very high. The worst type of valve lesion, short of Eisenmenger, is actually mitral stenosis. So the high maternal mortality if you do surgery with cardiopulmonary bypass. So balloon mitral valvoplasty works very well for these patients. It has to be done in the second trimester of pregnancy. So obviously, you don't want to do it in the first trimester because of the embryopathy, radiation exposure, and it's safe and effective. This is, I didn't put the reference here, but it's from Cleveland Clinic. It's just what to do with these patients when they are pre-pregnant and when they're pregnant. If they're pre-pregnant and if you can, and if it's possible, it's better if they don't get pregnant. If they do get pregnant before the pregnancy, you can do balloon mitral valvoplasty. If they have moderate mitral stenosis and symptomatic, again, it's advisable, it's actually helpful to do balloon mitral valvoplasty. But without symptoms, if they're moderate, they think you have to just optimize their medical therapy. But during pregnancy, if they have severe mitral stenosis on maximal medical therapy, and if they have symptoms, obviously you have to do balloon mitral valvoplasty, after the second trimester of pregnancy. This slide is probably, kind of summarizes everything. Primordial prevention is the most important, cheapest, and has to be done type of prevention for acute rheumatic fever worldwide. The disease, basically some experts say, shouldn't exist in this day and age, because if you think about it, it's a simple infection causing all these disasters and load on the health system down the road. So hygiene, reducing overcrowding, proper health preventive strategy, which is a primordial prevention, seems to be the cheapest and that works the most. Of course, we don't do a good job here, despite the attempts all over. A group A streptococcus infection does happen, will happen, and then treating it on time is very important. There is no vaccine nowadays. There are works in a pipeline, but there is really no vaccine that is out. And a skin infection doesn't seem even, that's why we don't know enough about this disease. If you get a skin infection with the same bacteria, you don't develop acute rheumatic fever. Why? We really don't know. Acute rheumatic fever, if you develop it, obviously secondary prevention, like we said, at least for 10 years or up to the age of 40, whichever is longer. And once you develop rheumatic heart disease, this is where we actually spend the largest chunk of healthcare dollars. So tertiary prevention, which is not usually successful and was not usually the best thing to do. So this is a major healthcare problem. Primordial prevention is preferred. Population dynamics, like I said, people move around a lot these days, so you cannot just say, I don't have this disease in my country and I don't have to know about it. It doesn't work anymore. Balloon mitral valvuloplasty is the procedure of choice, and surgery is complementary if they have these problems. Mitral stenosis and pregnancy, they're adversarial, and the future seems to focus on vaccines and some understanding of the pathophysiology of the disease, and thank you very much for your time. Thank you. Right. Exactly. I will tell you what so the question is, how common is mitral stenosis in our institution? So far from what I saw, we've done, in terms of procedures, we've done 3 or 4 mitral balloon valvuloplasties. I've seen a couple that didn't come for the procedure, but they were admitted for surgery or some heart failure. So the prevalence, the incidence, the prevalence of the disease is I would say, about 5 a year in terms of procedures in this institution. But Colorado and Utah, where the last epidemic happened, actually they do about 30. I looked that up, about 30 balloon mitral valvuloplasty a year, which they think is actually the downstream effect of the last mitral acute rheumatic fever resurgence back like 20, 30 years ago. But I'm sure Giorgio will know what happens. Yeah. Right. Yeah. Right. 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 Yeah. Yeah. Hmm. Yeah, absolutely. Yeah. Right. Right. Yeah. Sure, yeah. Right. Yeah, the only data that I found in the rate of recurrence of stenosis is in terms of the pathophysiology of the disease. It could be due to reinfection, recurrence of the acute rheumatic fever. It could be just the fibrosis from the prior attack. So that's what they mention in there. When patients actually present with mitral stenosis in this country and in the rest of the world is different. You don't see kids 18 and 20 with mitral stenosis here because the recurrence, if you have acute rheumatic fever, you get treated, so the chance of you getting recurrence is less. But if you don't get treated and you get recurrent, you can develop rheumatic fever early in life. So like you said, if they have acute mitral stenosis, you do valvuloplasty, and if there is recurrence, that's one of the mechanisms for restenosis. In those cases, you may consider lifelong antibiotic for secondary prevention with benzathine penicillin, which is given once a month, every 4 weeks for the rest of their life. Yeah, it's not a bad idea on a patient like that for the third time. She's in her 40s, so probably to put her on lifelong secondary prophylaxis. Thank you.